if you have an unnecessary scan at 36 weeks, simply because we want to check the baby's position or we want to just make sure the baby, if you intuitively feel the baby's growing fine and the baby's doing fine, that baby's doing fine. And if you do an ultrasound for no reason at 36 weeks, you have a 22% higher chance of having a cesarean section, simply because you did an ultrasound where they're going to find, oh, the baby's a little on the small side, or the fluid is a little lowish.
Welcome back to this week's podcast, and we have a reviewer of the week. This one is from AAL3, and she says, I can't recommend enough. Your episodes always make me feel more calm about everything pregnancy related. I asked questions on our Instagram, and you made another episode about it to answer my questions. Thank you for always catering to the women you serve and ensuring we are informed about what is happening during pregnancy, birth, and postpartum. I always recommend your podcast and the 3 exercises. I did the 3 exercises and had a fast labor and only pushed for 12 minutes with my first baby. Baby number 2 is due in July and hoping for a similar experience. Thank you again, Ashley. Thank you, Ashley. And I absolutely love that. And she's totally right. You guys, if you reach out to me on DMs and Instagram, that is me getting back to you. And I think it's super fun when there is something that keeps coming up and I can make an episode about it. So if that's you and you have questions, go ahead and head to Instagram at My Essential Birth and ask me there. All right, let me say that this episode with Dr. Stu was not exactly what I imagined when I wrote the outline and when we began our conversation. In fact, I had lots of questions around home birth and VBACs and twins and breech birth, as well as his experiences in those settings, because Dr. Stu is an OBGYN who turned to attending home births. And I just think that is fascinating. And it's such a blessing to have him doing what he was doing and attending those home births, and also supporting women in the ways that he supported them, and also what he currently does, which is speaking all around the world and teaching about breech birth and body autonomy and things that matter to women, particularly pregnant women. However, I do feel that the very in-depth and important conversation that we had, that this kind of turned into, will hopefully bless thousands of women to understand true informed consent and to be empowered to take control of their birth space and their birth experience like never before. So that is what I hope you guys gather from this conversation today. I'm also aware that this episode might make people feel uncomfortable. I think when you have somebody speak openly about the injustices that are happening in healthcare, and particularly during pregnancy, it makes us feel a little bit like we're in that flight or fight mode, which I think is totally normal. But more than anything, I hope this conversation will pique your interest and make you want to dive a little bit deeper into your own birth space and your desires, and hopefully give you the desire to go a little bit deeper for answers for yourself and how you choose to do that. Hopefully it starts with this podcast and then you guys move on to researching some things on your own. But if you do have any questions or comments after listening to this episode, make sure that you reach out to us at hello@myessentialbirth.com, or you can DM me on Instagram at myessentialbirth. We're always available to chat there. And with that, let's dive into today's episode. Today, you guys, I have a very special guest. This is Dr. Stuart Fishbein, known as Dr. Stu, and he's been practicing obstetrics for over 40 years. He's the co-author of the book Fearless Pregnancy, Wisdom and Reassurance from a Doctor, a Midwife, and a Mom, and peer-reviewed papers on home birth, home breech birth, and very soon on home twin birth, which I am really excited about. After completing his residency at Cedars-Sinai Medical Center in Los Angeles, California, Dr. Stu, as he's known by, spent 24 years assisting women with hospital birth, and then for the last 13 years has been a home birth obstetrician who works directly with midwives. He travels around the world as a lecturer and advocate for reteaching breech and twin birth skills, respect for the normalcy of birth, and honoring informed consent. Follow him on Instagram at Birth Instincts and at the Birthing Instincts podcast with midwife Bliss Young, as he offers hope, reassurance, and safe, honest, evidence-supported choices for those women who understand pregnancy is a normal bodily function not to be feared. His website is also www.birthinginstincts.com. Everything that I listed here is going to be in the show notes and clickable and ready for you guys, as well as the email for this week. So with that, welcome to the podcast, Dr. Stu. I'm really excited that you're here today.
Stephanie, thank you for having me. It's always an honor to meet sort of a new audience and a new host, and to be able to reach people who may, your audience probably has heard a lot of this stuff, but every now and then by osmosis, it gets out to more people, and they have to start to think, maybe the things that I've been thinking for my entire life are not necessarily true. We're learning more and more of those about all the things that we were taught in grade school and stuff may not be so true. So it's important that people are here, and I'm honored to have the opportunity to talk to them. So thanks.
Yeah. One of my favorite things just in reading and that intro and learning about you, I mean, how often do we hear about obstetricians that work as in home now, like as a home birth midwife or in a home birth setting? That's pretty intense. That's pretty amazing. I know that even when I was searching for providers, I mean, that would have been my like, yes, please. I love that you have both backgrounds. And I kind of wanted to dive into that just so people get an idea of where you came from. I would love to hear kind of what was that turning point? What brought you from obstetrics into the home birth setting?
Well, it wasn't an epiphany. It wasn't a desire from the very beginning. It was sort of a story of interactions with things that just drove me toward that direction. And it had to do with also my nature as a little kid, a little curious little boy who would always bug my mother by saying why, and never satisfied by the answer because I said so, which is what a mother sometimes does that when she's exasperated with her kid. And I carried that curiosity through college, and I didn't really have a direction in college. Some of my friends were going pre-med, and I didn't really have any direction. So I chose to do my pre-med classes, and I applied to medical school. And it was a different era back in the 70s. I got into medical school in 1978 at the University of Minnesota. And in your third year of medical school, people may not know this, your first 2 years are mostly classroom and some anatomy lab and other labs. Your last 2 years are generally clinical rotations. There are some core clinical rotations you have to do, like obstetrics and gynecology, internal medicine, pediatrics, surgery. Those are cores. And then you get electives like radiology, dermatology, ear, nose, and throat, things like that. So in your third year of medical school, I had just come off a rotation in hematology oncology, which I found quite depressing. It was pediatric hematology, and there were kids there with cancer, and some had died on our service. And my next rotation just serendipitously happened to be obstetrics and gynecology, and I was up at 3 a.m. catching a baby instead of dealing with a kid who's having a seizure because they have a fungal infection of their brain. And that sort of led me on the path to think that this is a type of medicine that I really like, because not only do I get to catch babies, but I get to do a little surgery, I get to do a little endocrinology, I get to do a little family medicine, I get to do a little psychiatry, and I get what I really wanted in medicine was longitudinal care. Longitudinal care is where you take care of somebody over time. There are only 3 specialties that really do that, and that would be family practice, internal medicine, and obstetrics and gynecology. Pretty much every other specialty is sort of whack-a-mole medicine. You break your arm, you go see a orthopedist, he fixes your arm, then you never see him again. You cut your forehead, you go to the emergency room, you see an ER doctor, he sews it up, you never see him again, that kind of thing. Or a radiologist or a pathologist who never sees their client, period. That wasn't the kind of medicine that I wanted to do. So I had to apply for residency programs at the end of my early fourth year of medical school when you are completely unprepared for this decision. You're very naive, you don't know anything, you're enthusiastic, but you have to make a decision in the third or fourth year of medical school that's going to affect you for the rest of your life. Because once you get on that path or that river, it's very hard to get out. It's very hard to change. And so I applied for residency programs. I matched in Southern California. Matching means it's a very interesting thing. Again, kind of an exciting day. It's a sliding door moment in your life, which sometimes we have them and don't recognize them. This is one that you can recognize. On the third Wednesday of March, across the country, every fourth year medical student gets an envelope that they open up, and it tells them they've been applying for residency programs, and the residency programs have been ranking the interviewees, and we've been ranking where we want to go. It all gets put into a computer. It's called the match, and we get an envelope that tells us where we're going to end up. And I ended up matching in Southern California at Cedars-Sinai Medical Center in Los Angeles, which is a very good hospital. But it wasn't even my first or second choice. It was my third. It was down in my third choice. My first choice was actually University of Colorado. My second choice was actually University of Iowa. People ask why, and it's a long story. We're not going to get into that. But I matched in California, and because I matched in California, my life took a turn that I never would have seen it taking. First of all, I was very lucky because my residency program was affiliated with LA County USC Women's Hospital's program. They were the busiest hospital in the country in the early 1980s, doing about 22,000 births a year there. If you break that down, that's 65 babies a day. We as Cedars residents spent 4 months there, and we were there every other day. So that's 60 days, 65 babies a day. You can do the math that you're seeing about 3,600 births in a matter of 4 months. And of course, 3% of those are breaches and 3% of those are twins. And so you're seeing a couple breaches and a couple sets of twins every day. And we found them to be just a variation of normal. As a matter of fact, we used to fight over them. We used to, the senior residents or junior residents would kick out the interns because they wanted to do the breech deliveries because it was fun. And it was just considered normal. And somewhere along the line that changed and it became, oh, it's too scary. We can't do them. And we have to do C-sections on all of them. And they stopped teaching those skills. But nonetheless, I finished my residency program very medicalized. So I was what I consider now the unethical, crazy doctor wearing the full hazmat suit, making you give birth with your baby and with your back, laying on your back with your legs up in stirrups, covering your legs with blue drapes, washing off your vulva with betadine, catching your baby, immediately cutting the cord. No such thing as delayed cord clamping in those days. Stupid. So many things we did were so stupid. The next biggest stupid thing is we showed you this beautiful thing that you just delivered. Your arms are out wanting to hold your baby, and we would take the baby and walk it across the room and set it down in the warmer. And that's how birth was done. And still in many hospitals, that's still how it's done. Baby doesn't go on the mom's chest. The cord is not left alone. But that's how we did things. And obstetrics was a different world back then. You didn't come out like you do now and probably get a salary, go to work for somebody, get a job, work a shift. That's what medicine is like now. And I have to admit that probably leads to a better lifestyle, but I can't imagine it leads to better job satisfaction because you are taking care of somebody for 12 hours and then you're gone and you don't even know what happened to them. And you're taking care of people you don't know, and the people you do know end up being taken care of by people they don't know. And it's a lousy system. But when I started, we built our own practice from scratch. So I covered free clinics. I covered emergency rooms. I took call for other doctors when they went on vacation. I assisted them in surgery and slowly but surely built up my practice. And one of the things that fortuitously, again, happened to me early in my practice was I was approached by some local midwives and asked to take their home birth transfer. And I said, sure, not because I thought home birth was a good idea and not because I thought midwifery was a good idea. I'm pretty sure I thought it was stupid, just like most of the OBs still do to this day, because that's what I was indoctrinated to believe, that birth is a dangerous thing and only hospitals can save women from themselves. But I started to learn a different way of doing things by working with the midwives. And I saw that their transports were very well educated, were not emergencies, just needed some rest, usually an epidural and some Pitocin would deliver vaginally. And I had a lot of time to sit and talk to the midwives. And I was enamored with the model by which they cared for because it was so different than mine. And I was open-minded enough to start to go to some of their meetings and some of their peer reviews. And I was invited and included. And I think they thought it was a good thing too, because I was an obstetrician who was showing interest in them. And I began to see that everything that I was doing was inappropriate for about 85% of pregnant women, that I didn't know anything about normal pregnant women. When you're a resident, you never watched normal labor. If your listeners have seen Business of Being Born, there's a scene where they ask these 3 female residents if they've ever seen a normal childbirth, and none of them have seen one because in the residency world, you're called to the room when you're asked to do something. So for us, being in the labor room, we get indoctrinated or we get our culture is that we're there. We must do something because we're there. That's because that's how we're trained. So we put on a glove and we do a vaginal exam that might not be necessary. We break someone's waters. We order Pitocin. This is how we manage labor, as opposed to not managing labor, as opposed to sitting in a chair quietly watching for an hour and then quietly saying, wow, you're doing great, and leaving the room. That would be something that would be remarkable, but will never happen in current residency system as it exists today. So I began to see a different way of doing things. And after about 10 years of medicalized birthing, I opened a collaborative midwife practice in another hospital in north of LA in Ventura County, because Cedars-Sinai did not allow midwives to have privileges at that time. And these two certified nurse midwives and I built a practice called The Woman's Place. And for 15 years, we had a really good thing going. But we were never accepted in the community. We were always picked on. We were always ostracized. We were always selectively peer-reviewed when they weren't peer-reviewed for similar or worse things that happened. And after 15 years, they decided they found a way to get rid of us. And first they banned the midwives, and they banned VBAC. Then they banned breech delivery. And then they threatened me with not renewing my privileges. They couldn't really kick me off staff without a legal battle, but it's their football. They can decide, we don't want you here anymore, and we're not going to offer you an invitation. It's like a golf club. Golf club has the right to not renew your membership, and then you have the right to decide whether you want to fight them or not. But fighting a hospital is a losing battle for most people. So I had very good advisors, and I had great friends in the midwifery community at that time who said, Stu, come and do home births. I even had my clients who were due after the date that I was supposed to be, have my privileges ended, that said, this is great. We wanted to deliver at home, but we really wanted you, so we were going to go to the hospital. Now you can come and catch us at home. So I did, and I'll have to tell you, after 25 years of backing midwives, I had yet to be at a home birth. That's so typical because there's no mixing of the silos. So I went to my first home birth, and I was a little nervous, I have to tell you. I go with midwives. I always went to birth with midwives who made it very easy for me. And but I was the person who said, like, geez, what happens if this happens? What happens if that happens? Not understanding birth, even after all those years of backing midwives, because I was still living in the hospital-based model. And then over the next 13 years, I did home birthing, and I got braver. And I started to do women with medical issues like diabetes and hypertension. I said, why can't they have a home birth? And I started to do breeches and then twins and babies sometimes with Down syndrome. You know, why do they have to be denied that beautiful moment at home with their parents, skin to skin, microbiome, epigenetics, the experience the mother has? I mean, one of the longest lasting memories a woman will ever have is the birth of her child. And so many women don't have good memories of that. Women are more concerned about how they're treated in pregnancy and labor than how they actually delivered their baby. And when women aren't treated well, that sticks with them probably for the rest of their life. So the birthing model, I just began to see the common sense that it made to treat birth as a normal function of a woman's body. And this is, again, most of my wisdom comes from the wisdom of midwives, passed down through eons. And I would not be the person I am today without giving gratitude to the midwives I've worked with and the ones that came before them. So then I began to publish papers because I'm not an academician. I don't really like doing that, but I felt it was important enough. And so I published a paper on home birthing. I published a case report on a set of twins with a breech first twin's head got stuck on the second twin vertex, something called interlocking heads, which supposedly never happens, but scares all the doctors out of doing breech first twins. Of course, they don't do breech now at all. But I created a simple maneuver that solved that problem, and I published a paper on it. Of course, I couldn't get it published in any of the premier OBGYN journals in the United States. I had to go to an international online journal, all access, so people can find it. And I even spoke to the editor of the Green Journal at the time. Her name was Nancy Cheshire, and we had a good conversation. And she said, Stu, I'm paraphrasing here, but she said, Stu, our peer reviewers just aren't ready for you yet. So your stuff isn't going to get through peer review. So that's a preface to what was coming in the era of censorship and how, journals now publish articles that benefit the agenda that they serve and block articles that don't. And we all saw that with the COVID articles and the hydroxychloroquine articles and the ivermectin articles and the false articles about how effective and safe COVID-19 vaccine was. And when a journal is sponsored mainly by Big Pharma, or the newscasters are sponsored mainly by Big Pharma, you're not going to see them running negative stories or printing negative journal articles about it. And so I've learned a lot. And then age caught up to me, and being on call every night for 40 years, every night for 40 years. Even when I was on vacation, I didn't turn my phone off. I took calls. I got real tired of doing that. And so I had to give it up. And I now found a new mission in life, which is helping women with questions and the podcast, and going around the world and teaching my 2-day twin and breech home birth seminars, or not necessarily home birth, but skills seminars that are very well received. I'll be going to Australia for 6 weeks coming up this August. I'm teaching 6 seminars, plus I'm speaking at a conference whose name I love. It's called the Convergence of Rebellious Midwives, and I'm really looking forward to speaking at that. And finding that slowly but surely some doctors are coming around to it, but most doctors, because of the way they're trained, because of the financial constraints on them, because of the medical legal constraints on them, are not likely to change anytime soon from the model in which they are feeling most comfortable, despite the fact that they have to know that a lot of what they're doing is a violation of every basic tenet of medical ethics, and yet they continue to do it. And part of my talks, when I give my 2-day seminar, is a whole lecture on why things are the way they are. And I talk about cognitive dissonance and stage 1 thinking and mass formation psychosis, and how doctors could go along with certain things knowing that they're wrong. It's a fascinating stuff. I hope that people, this is a long story. I don't want to take up the entire podcast with my story. I could easily do that, but I could monologue the whole hour. But that's how I got to where I am right now. And I wish I still had the energy to do deliveries. I actually miss being at birth. I do not miss being on call.
Yeah, I understand that for sure. And I appreciate the background in that story, and everything you kind of talked about there. I think there is this, I think a lot of people are asleep, and it's really nice when we have an opportunity to wake them up a bit. So I appreciate all the things that you mentioned there. And I think too, just the importance behind, as moms who are pregnant today, understanding what's happening. And it's not that the people that they're interacting with are necessarily bad people, but the way that they are trained and the constraints that they have make it very not conducive to what we would hope to have out of our experience as pregnant and birthing women. And that's what leaves us, as you were saying, how we're treated. That's what leaves us feeling like, what just happened? That was not the experience I wanted, even if you can't pinpoint what it was. So I think everything that you said was just nail on the head and really, really important to be said. So thank you.
On that point, I'd like to just add that happy people do not treat other people badly. It's really rare for that to happen. Unhappy people treat other people badly. They kind of want to spread their misery. You can call it, I think Christiane Northrup calls it, what they call energy vampires, I think is what they do. But when a doctor snaps at a patient, or a doctor rolls their eyes at a patient, or a doctor stomps out of the room as a patient, or a doctor uses subtle or overt coercion, or pulls out the dead baby card, that's not the way you talk to people if you're happy. So I feel for my colleagues that are stuck in the hamster wheel that they're stuck in, but it's their own fault for not having the bravery to get out. And I know so many labor and delivery nurses who left and had the bravery to get out because they couldn't stand watching what was going on in labor and delivery every day and not hurt their soul. And so I do feel for my colleagues who are stuck in that. Some of them believe what they're doing is the safest thing to do. And for those people, they're lost, they're hopeless, because they cannot believe that what they're doing leading to the outcomes we have in the United States makes what they're doing good. The fact that they refuse to look at outcomes, the fact that they refuse to look that the C-section rate has risen 500% in 50 years, and the rate of cerebral palsy or hypoxic ischemic encephalopathy, as we call it, or stillbirth, has not fallen, commensurate with any sort of intervention that they've done. The induction rates have gone up to 40% induction rates now, that women can't go into labor spontaneously. They can't deliver vaginally. When did that become the norm? And how does a doctor who does that, who comes home at night thinking they did 3 C-sections a day, thinking that they were all absolutely necessary, when probably 2 out of the 3 of them were not necessary? How do they justify that? And that's where things like cognitive dissonance and confirmation bias get into play. And they're fooling themselves because it's so uncomfortable to realize after 20 years of doing something, wait a minute, you know what? I've been hurting people all my career. That's not what I signed up for. So it's easier to become part of the collective and ostracize those of us who point that out to them. It's kind of like what happened during, again, another example, like during COVID, where people who lived next to people for a decade, their kids played with each other. Suddenly your kids couldn't play with the neighbor's kids anymore because you weren't vaccinating your kids and they were out in the yard playing without a mask on, and the neighbor was freaking out and calling the city and turning you in. How does that happen? How do you go from being friendly neighbors to being, enemies in a matter of months? And I know the answer, but it's Matthias Desmond wrote a book called The Psychology of Totalitarianism. If your listeners have time, it's a book I read it on Audible. It's a book worth reading because it explains what's going on. And it can be very clear this is what's going on in medicine as well. Why don't doctors see that their outcomes are so bad that they need to make a change in their system? They don't. They defend the system. And then they have organizations that are completely bought off, like the American Academy of Pediatrics, the American College of OBGYN, or the American Medical Association, who are not responsive to their members anymore. They're responsive to the organizations that give them big money, and the government. Like ACOG took $11 million plus from the CDC to push the COVID vaccine onto pregnant women. The AMA makes 80% of its revenue from the billing coding system that it has a monopoly on. So only about 14% of doctors in the United States belong to the American Medical Association, yet the news media quote the American Medical Association as if they represent all doctors. It's all a lie. It's all, and once you start to see it clearly, you can't unsee it anymore. It's like wearing my T-shirt. It says, it's not my skepticism that should concern you. It's their certainty. Because they're so certain that they're right. That would be a red flag for anybody. And by the way, people like me are willing to talk, and we have the time to debate. We have the time to listen. The medical model doesn't even give doctors the time to listen. You've got 6 minutes or 7 minutes for a prenatal visit because of how complicated it is regarding your reimbursement is so low, your overhead is so high, you have to do volume. And when you're doing volume, you can't possibly give the same sort of attention and care. I'll give you an example. I've had 4 eye surgeries this past year. And I've seen the same doctor probably 15 times. I can hear him in the hallway when he comes into my room. He pulls the chart out and he goes, Stuart Fishbein, Dr. Fishbein. Blah, blah. He doesn't even know me. When he opens the door, he recognizes me, but he doesn't remember me because he's doing so much volume. It's not a great way to live. And so it makes them unhappy to bring this whole conversation full circle. And when you don't know somebody, when they're outside your line of sight and you're unhappy, you don't necessarily have to treat them well. And that's what happens in the hospital a lot of times, is the nurses are overworked and they're short with you because you decided, you want to ask a question about why do I need an IV? And they don't have the time to answer you. So they get short with you.
Yeah, kind of on that actually. And we definitely talked about that on this podcast. I noticed, like you were talking about the induction rate, for example, and I feel like I am preaching this left and right now because it was certainly happening before 2020. But I feel like as soon as 2020 hit, it skyrocketed, at least even with the women that I was talking to, the women that were taking my course, the people that were, the questions I was getting. And it's like, Arrive trial. So I've done podcasts on Arrive trial and we've talked about this left and right, but But inevitably, every single mom that has an obstetrician that is delivering at a hospital right now is being offered an induction. Let's schedule your induction for 39 weeks at their 36, 37, 38 appointment, no matter what kind of conversation you've had from the very beginning about induction or about being able to, go till 41 plus or whatever the conversation is. For women who are listening, and since you've definitely seen this as well, what can they do? What do they need to know? What do they need to know about induction, the safety of their baby being in their body longer? And I would say even particularly for women who have quote unquote concerns where they're like, we're talking about being over the age of 35, which, is just another number. But things like that, where the doctors are like, no, like if you do not do this induction, like you said, like dead baby is the conversation that we're having. It's like an instant jump to there. What do you say to them?
Okay, so this is a good one because I love this. I love this question. First, let me just say that the United Kingdom put out its data from 2023, and we all thought that England had a pretty good maternity care system integrated with midwives and stuff like that. And overall, their numbers were horrific and surprising to me. And one of the things that you mentioned was the rising induction rate. And you're right, the induction rate has been rising for the last 15 or 20 years. But in 2020, the rate of the rise increased. So it rose faster, and it's been continuing to rise faster. The ARRIVE trial was probably done because they wanted a reason to induce. This is one of the things when people look at papers, they need to understand three main things when a paper comes out or a news article comes out. And you have to take a step back and you have to ask yourself these three questions. There are probably more than three, but these are the three main ones. Why is this article coming out now? Or why is this journal paper coming out now? Did the author have any conflicts of interest, whether they declare them or not? Because there are authors who declare they have no conflicts of interest, and yet they do, because they work for the journal in which they're on the editorial staff of the journal in which their paper got published. That by definition is a conflict of interest, although they just don't see it that way because of basically cognitive dissonance. And the third one is who paid for the study. You have to look at these things, and sometimes they're not easy to find. But don't just read a headline, and don't just read an abstract or a conclusion on a paper. The meat of a paper is in the material and method section. They may come out with something that says, "Oh, this is conclusive that this should be happening." Well, first of all, no paper is ever conclusive. A paper is just a piece of data. And as we know, there are papers that come out that a year later the paper is refuted, or other papers come out saying something different. But when a paper comes out and says something definitive, you have to look at the material and message section. Oh, there were only 12 people in the study. Oh, the safety testing on that vaccine was for 4 days. Oh, well, now, wait a minute. That doesn't really make it definitive, does it? So you have to look at that sort of thing. So your question is what to do when you're being told things. How do you know whether they're true or not? Well, first of all, everybody listening should understand that pregnancy is a normal function of your body. And it rarely goes wrong when you leave it alone. Occasionally it does. But the medical model is always on the alert for something. They're always going to be looking for something. They're always planting seeds of doubt. I don't think they mean to do it in a mean way. I just think that this is the way they're taught, and they never think outside of their box. So when a doctor sees you for the first visit and finds out that you are 35 years old, or even worse, you're 34 now, but you'll be 35 before your due date. Okay. Now you're in a high risk category. Like what? Really? It changes like from 34 years and 11 months and now 35. Or if you have a diabetes screening and 139 is normal, but 140 isn't, or how do bacteria know when 18 or 24 hours of ruptured membrane